Hi, I'm Mohammed Jahanzeb. I'm a medical oncologist in Boca Raton, Florida. I focus on lung cancer and breast cancer, and I work with Florida Precision Oncology, a division of 21st Century Oncology.
Hi, I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C.
I'm Michael Lanuti. I'm a thoracic surgeon at Mass General Hospital. I'm the director of thoracic oncology in our division of thoracic surgery, and I'm an associate professor at Harvard Medical School.
Hi, I'm Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I am chief of thoracic radiation oncology and stereotactic body radiotherapy and director of clinical trials.
Hi, I'm Michelle Ginsberg. I'm a radiologist and I'm director of cardiothoracic imaging and vice chair for education at Memorial Sloan Kettering Cancer Center in New York City.
So this is a 68-year-old who presented with some increasing dyspnea on exertion and didn't approve with a initial conservative management. They went to the emergency department and they got some chest imaging, which we'll show in a moment. Remarkable to their immediate history, they had dyspnea, fatigue, they'd had some considerable weight loss, and they also had hoarseness. But their overall performance status was 1. They were burdened from a medical standpoint with arthritis and AFib and some reflux, obstructive sleep apnea. Again, no prior history of radiation or connective tissue disease. They had a remote smoking history and were retired at home with their wife, and no really remarkable cancer history. And the PFTs here are relevant in this case. You can see that their FEV1 was 2.6 liters and the DLCO was 76%. So here's the initial diagnostic workup imaging for Dr. Ginsberg. We have the CT on the left upper panel and then the subsequent PET CT and then some biopsy imaging, which I'll talk about after she discusses the CT and PET.
We see that there is a large anterior mediastinal mass that measures 7 by 8 centimeters. And more inferior to that, we also see a pericardial effusion, which is moderate size, and a small left pleural effusion with some compressive atelectasis next to it. The corresponding PET CT demonstrates that the mediastinal mass is FDG avid, but there were no other lymph nodes that were avid in the mediastinum. And on the bottom left-hand corner, we see a transthoracic needle going into the mass from a biopsy. And the MRI of the brain was negative.
Yeah, so as you can see, this patient has some, multiple kind of concerning imaging findings. Obviously at the top of our differential was some sort of a thymic tumor, although that includes other things as well. The biopsy revealed a squamous cell carcinoma, so consistent, to the extent that we can tell that with pathology with potential thymic carcinoma. They did do EBIS FNA as well, so there was actually an endobronchial ultrasound guided biopsy of multiple nodes. Those nodes were not FDG avid on the PET CT, but because of the incredible influence it would have on subsequent decision making, we got biopsies and they were negative. They also sampled the pleural fluid, which was negative at least by one cytology and did not recur, and sampled the pericardial fluid as well. So this patient had quite a considerable number of samplings, and that was also negative. So this patient was deemed to have a advanced primary thymic carcinoma. It was without evidence of lymphadenopathy or any evidence of distant disease. And so I'll pause there for discussion of optimal treatment options.
Sure. So, Dr. Lanuti, you being the surgeon with all of these other areas, pleural effusion, pericardial effusion being negative, nodes being negative, as advanced as it looks on the scan, would you still be tempted to attempt surgical resection?
I think it would be reasonable to pause here. And are we missing something? So for a thymic neoplasm to show up with a pericardial effusion is not that common, and often, if it is seen, can be associated with malignant disease. Things that can happen with thymic malignancies are drop metastases in the pleural spaces, even though you don't see them on the CT or even FDG avid on the PET. I think an MRI, we often use an MRI to exonerate potential pleural metastases to suggest stage 4A disease. So one could get the MRI, one could even take a look in the pleural space with a video camera, left VATS, to take a look and see if there's disseminated disease. If you exonerate all those things, you still have to explain the pericardial effusion, and maybe there's some other etiology of that that's cardiogenic, but it's a careful discussion about whether you should go right to surgery.
But if you take this approach that you just described, doing an MRI of the chest and doing the VATS camera, would you take the patient to the operating room once with both consents and do the VATS camera and then proceed, or do you do that as separate procedures?
I think that's a good question. I think if you're very suspicious that you're missing something, you would separate those two. If you thought that you could explain the pleural effusion, the pericardial effusion by some other etiology, you could put them all together. I would try to, as I'm just sort of seeing this, I'd say I might separate them to get me a little bit of biologic window to see what's going to happen. But the other is that if we think this is completely resectable, we often consider surgery. If there's lots of sort of local invasion into adjacent large structures where a complete resection is difficult, we would ask our colleagues for some kind of induction chemotherapy regimen prior to resection.
Yeah, I was going to that. I asked you that next. Would you seek help from Dr. Levy here or not? Dr. Levy, seems like your help is being sought. So what do you propose?
Yeah, these are obviously don't have a lot of data like we do in non-small cell with potentially resectable thymic carcinoma. And this is obviously, as we are here today on Zoom, on this virtual platform, this is a multidisciplinary discussion about the role of neoadjuvant or perioperative chemotherapy. If the surgeon has turned to me and say, look, this is something where I think we need to start with chemotherapy first, we've really got two regimens that could be considered. One is a CAP-based regimen, cyclophosphamide, adriamycin, and cisplatin. Response rates in the neoadjuvant setting range anywhere in small series between 30 to 70%. So you can elicit responses neoadjuvantly prior to surgical resection. So that is a consideration for patients who you want to be aggressive. The other regimen that has been utilized is carboplatin paclitaxel. This is we've learned more and more about the potential utility of this specifically in thymic carcinoma. So patients that are potentially resectable usually are fit enough. I will give them the benefit of the doubt and try the 3-drug regimen, although it's not easy, of CAP. And if not, then consider full dose 4 cycles of carboplatin prior to surgical resection.
Great, but as you know, first of all, you point out correctly that these cases are far less common than lung cancer. Rather than talking about a couple of 100,000 cases a year, we are talking about 400 cases a year of this type of malignancy that we encounter. But these days, immunotherapy is all the rage, and the 2 regimens that you mentioned are chemotherapy. Is there a place for considering immunotherapy in these patients with thymic carcinoma as opposed to thymoma, where there are issues that you can mention?
Yeah, I think we have some data on specifically pembrolizumab from a phase 2 trial in the refractory setting. Patients who have received platinum-based chemotherapy in the advanced stage who are progressing. There is data with single-agent pembrolizumab showing reasonable activity. I'm not aware, and there may be more data recently that I'm not aware of, looking at adding immunotherapy to chemotherapy for thymic carcinoma. But the data that I think has been published, and I think Beppe Giacconi is the lead author in that study out of Georgetown when he was there, showing reasonable response rates and decent activity in the second line. But there may be some data first line, I'm just not aware of it.
No, that's good. And you want to mention why it may not be a good idea in thymomas?
Right. So thymomas may have associated autoimmune phenomenon, myasthenia, and other things. And by giving immunotherapy, you may worsen an autoimmune phenomenon that's associated with thymomas.
Any comments from Dr. Robinson on, let's say, there is successful systemic therapy, shrinkage, then surgical resection, and we find out that a margin was positive?
What a tremendous segue. In this case, the patient received induction carboplatin and paclitaxel and achieved an imaging partial response. The patient then went on to a left hemiclam cell resection with en-bloc resection of the tumor and a bovine pericardium reconstruction. They also needed to resect the involved innominate on that side. The final pathology revealed, again, poorly differentiated squamous cell carcinoma, 9-centimeter tumor, invading the left upper lobe, pericardium, and innominate. There was a modest treatment effect from the induction chemotherapy. And the final specimen revealed carcinoma present at the inner pericardial surface and focally on the inked margin. And there was 2 of 8 lymph nodes resected along with that. They were considered to be so-called perithymic, and they were positive, leading to a final pathology of a YPT3N1 with presumed focally positive margins.
So what did you offer the patient at that point?
Yeah, so I think, this is, again, it's kind of layers of lack of evidence one way or the other. With thymoma itself, not thymic carcinoma, there's considerable debate about the role of postoperative radiation in a setting where you either have microscopic or macroscopic invasion. As the degree of invasion or the involvement of adjacent structures goes up, there seems to be some retrospective evidence of a benefit for local control. In this case, I think because of the extent of the disease, the perithymic nodes, and the focally positive margin, we did offer this patient post-operative radiation. This is a great example, again, of multidisciplinary care, however, because it's imperative that you end up speaking with the surgeon of record to understand their operative concerns. They often have a excellent understanding of where exactly that margin may be, in discussion with the pathologist. Sometimes even in anticipation of that problem, our surgeons will leave clips behind as a mechanism to help us guide postoperative radiation.
Great. So in terms of positive margins, just for the non-physicians, can you explain what we call a positive margin?
Sure. Maybe I should let Dr. Lanuti elaborate on that, because there's a lot of discussion between our pathologists and the surgeons about.
Yeah, that's true. So Dr. Lanuti, go ahead.
Yeah, so thymic neoplasms tend to be locally aggressive, and we often try to do a complete resection if it's safe and reasonable. We do take local structures, be it pericardium, sometimes phrenic nerve. The brachiocephalic vein can be taken with some impunity, but I can't emphasize enough that the surgeon should be the one to discuss where the positive margin is, because when the specimen comes out, it has to be very well labeled, and only the surgeon really knows where they were fussing over the possibility of a positive margin, or they got an intra-op frozen section. The margin being positive generally a pericardium or the perithymic fat along the phrenic nerve. And so I think, to be pointed into a direction and help Dr. Robinson, I think it's an incumbent upon the surgeon to actually do that.
Sure. So you drop the specimen in ink and then it's sliced like bread. And you look at those slices under the microscope, and if there's cancer cells touching the ink, that means there were more cancer cells on the other side of the knife. Is that the idea?
That's very well stated.
Okay, great. So I think this was a great case. Again, like you said, it required expertise of the whole team, and it was teamwork. Cancer care is team sport, as we say. This has been a truly enlightening discussion. I thank all of you. These were phenomenal cases, all requiring multidisciplinary input, and it's such a treat to have world-renowned experts discussing them and coming to a consensus. Thank you all.